really helpful for the upcoming next examination that we have. You can also book a slot for personalized counseling session, wherein you'll be given a mentor and a buddy, and they'll be like your friend. You can share every whatever the problems that you have, whether it is academic or otherwise, with them, and they'll help you uh, reach your goals. They'll give you a study schedule, and they'll give you everything that you need for your examinations. And we also offer 3 different models of subscriptions: the basic, standard, and the premium. And in the basic, you just have the pre-recorded classes, live class, and live doubt clarification, quick revision exam modules. In the standard plan, we have, along with all those 3 features, we have live doubt clarifications as well. And in the premium plan, it's all-in-one kind of plan, wherein you have everything, including the personalized guidance. You can use my coupon code Dr. Sushma 20 for any additional subscription across all 3 subscription plans. Okay. Yes, with that, today we'll be dealing with GIT development 2, right? The hindgut and related structures. And we have come to the end of embryology, almost just one more class left to understand the male urogenital system. That's the only one class that is left out. But today's class is about midgut and hindgut. Okay, it's going to be really interesting class, and we will begin. Okay, so guys, in yesterday's class, we learned about the development of foregut. So if we have to just recap, from oral cavity till the major duodenal papilla is the foregut. From the major duodenal papilla till the lateral 1/3 and the medial 2/3 of the transverse colon is the midgut. Then whatever that is there below that is going to be the hindgut. All right. Now let us look at the derivatives of the midgut. Midgut involves the small intestine, including most of the duodenum. Is it not? Major duodenal papilla is the place where the bile duct opens into, and whatever that is there below that will be the derivative of the midgut. And of course, cecum, appendix, ascending colon, and the right half to 2/3 of the transverse colon, the medial 2/3 of the transverse colon is belonging to the midgut. Let's look at the clinical case scenario. A 3-day-old neonate presents with bilious vomiting and abdominal distension. Correct? So there is bilious vomiting. In itself is a clue. That's a buzzword. Then it also has abdominal distension. Okay. On examination, a palpable mass is felt in the right lower quadrant. Which of the following conditions is most likely responsible for this presentation? We will come back to this towards the end of the class. Okay. Yes. Now, what are the derivatives of the midgut? And all of the midgut derivatives are supplied by superior mesenteric artery. They are supplied by superior mesenteric artery. Now, the midgut loop is actually suspended from the dorsal abdominal wall by an elongated mesentery. In yesterday's class, what did we learn, guys? Mesentery is something that holds the abdominal wall, attaches the abdominal, all the contents of the gut into the body wall. In the foregut, we had what different? What did we have? We had a liver coming like this, dividing the mesentery into 2. Remember all those things. They're all very, very important, guys. You cannot afford to get those questions wrong. But here also, midgut loop is suspended by elongated mesentery. Okay. As the midgut elongates, it forms a ventral U-shaped loop of gut, which is called as the midgut loop. Now, it projects into the remains of the extraembryonic coelom in the proximal part of the umbilical cord. Okay, right. Then, at this stage, in the intraembryonic coelom communicates with the extraembryonic coelom at the umbilicus. Now, this movement of the intestine is a physiological umbilical herniation which resolves at its own, right? It occurs in the beginning of the 6th week, but generally it has to resolve. Otherwise, what happens? Then there will be, what happens? Wait, 1 second, guys. Let me just pull it up. Just hold on a second. . Yeah. Now, this umbilical herniation occurs because there is not enough room in the abdomen for the rapidly developing midgut. Okay, midgut has so many structures, guys. There's duodenum, and then there is transverse colon, there's ileum, cecum. There is so much of contents that is growing. So the developing abdomen cannot accommodate so much. So that is why this umbilical herniation happens. So whatever the structures that are developing is actually present in the intraembryonic coelom. If you remember, the yolk sac, where is it present? Is it present in the intraembryonic coelom or extraembryonic? It is in the intraembryonic coelom. So this communication between the intra and the extraembryonic coelom is what is responsible for the herniation of the contents. Is it not? They are responsible for the herniation of the contents, and this herniation occurs because there is not enough room in the abdomen for the developing midgut. Now, the shortage of space is caused mainly by the relatively massive liver and two sets of kidney during this stage of development. Now, the loop that is formed over here, it has a cranial limb and a caudal limb. Okay, it has a cranial limb and a caudal limb. The yolk sac is attached to the apex of the midgut loop where the two limbs join. Where the two limbs join. What yolk sac is that? Is it primary, secondary, or definitive? It is definitive yolk sac. The entire gut develops from the definitive yolk sac. All right, you can see here how the yolk stalk is attached to the developing loop. Is it not? Is it not? Now, what do we see here? This is the cranial limb and this is the caudal limb. This is how the rotation of the midgut is taking place. And you can see the stomach here and the dorsal pancreatic bud. This is the gallbladder, the umbilical cord. Sorry guys, I made a mistake. It is yolk stalk, not yolk sac. Okay, it's the yolk stalk. Sorry, I made a mistake there. Let me correct myself. Yes. All right. You can see the spleen. You can see the dorsal aorta that is supplying the midgut. Okay. This is the dorsal pancreatic bud. Then, now the cranial limb grows rapidly and forms small intestinal loops, whereas the caudal limb undergoes very little change except for the development of the cecal diverticulum, which is primordium of the cecum and the appendix. So appendix and cecum is developing from the cecal diverticulum. All right. As you can see now, you can see the cranial limb is growing rapidly and forms small intestinal loops. Can you see these loops? This is the cranial limb, right? This is the cranial limb. This is the caudal limb. Whatever the structures are forming has to form from these two limbs only. Is it not? Is it not? So, as the cranial limb grows rapidly, look at the space. Is the space increasing? No, the space is not increasing. This is the remaining. This is all the space that it has. But the cranial limb is developing rapidly. So what should it go? It forms these loops of intestine. This is the reason why we have such a big intestine packed into such tiny cavity. Is it not? We have almost 10 meters of intestine, but then it is packed into such small cavities. Why does it happen, guys? Because of this. Because the developing caudal limb, it starts to develop so rapidly, but the space that is available for the development is only so much. So it undergoes this coiling, and that forms the loops of the intestine. Understanding? Now, which structure is responsible for the rotation of the midgut during development? Superior mesenteric artery, because around the axis of the superior mesenteric artery itself, the rotation of the gut actually takes place. Now, let us look at how the rotation of the midgut loop takes place. All right? Yes. Now, while it is in the umbilical cord, the midgut loop rotates 90-degree counterclockwise around the axis of the superior mesenteric artery. Look at this question, guys. Which structure is responsible for the rotation? Superior mesenteric artery. So, the midgut loop that is formed undergoes a counterclock rotation like this, and the axis of rotation is superior mesenteric artery. If the superior mesenteric artery is like this, and it undergoes a counterclock rotation around the superior mesenteric artery. Because of this, what happens? This brings the cranial limb to the right and the caudal limb to the left. Because now imagine, guys, if we have two limbs like this, if they're undergoing a rotation like this, what has happened? The cranial limb has come this side and the caudal limb has gone that side. Meaning the cranial limb has come to the right side, the caudal limb has gone to the left side. Right? From the caudal limb, what did we have? All of the cecum, appendix, and all of these structures were forming from the caudal limb. From the cranial limb, I have the loops of the intestine. Let's see further what happens. During the rotation, the midgut elongates and forms intestinal loops, which are the jejunum and ileum. As the cranial limb is, sorry, as the midgut is rotating, the cranial limb elongates and it forms the intestinal loops. Okay, you can see now how the rotation is taking place. You can see it is rotating like this. The rotation is actually like this around the superior mesenteric artery. Around the superior mesenteric artery. Okay, yes. Next. Then, how does the midgut loop return back to abdomen? So, what did we learn initially? Initially, we learned that the abdomen is too small for the developing midgut. Abdomen is too small for the developing midgut. So that is why the extra-embryonic coelom and the intra-embryonic coelom started communicating with each other, and there was herniation of the contents. Herniation of the intestines. Is it not? It was physiological. But during the 10th week of development, the intestines actually return to the abdomen. But what causes its return is still a mystery. We don't know what triggers the return of this intestine. Unlike, guys, what was happening during the development of heart, what was happening? We had so many signals. You had so many signals. You remember, I told you there was retinoids which were acting as signal factors. There was Ig, growth factors, and so many other factors were actually signaling. Even for the formation of the cardiac loop, we had signals. But here, for the return of midgut loop back to the abdomen, we don't really know what it causes. Okay, maybe one of the things is the decrease in the size of the liver and the kidneys and the enlargement of abdominal cavity may trigger, but nobody knows at what size or at what the developmentally speaking, at what stage they come back, we don't know. But around 10th week, the intestines come back to its original this thing, that is abdomen. Okay, but as such, if you ask the question why, we don't know why. The question is, if you ask why, then we definitely don't know why this happens. And this process is called as reduction of the physiological midgut hernia. Okay, if this process does not happen, let's say, if this process does not happen, then what happens? Those are the questions. Then there are so many conditions that when the midgut fails to return back to its position into the abdominal area, that is where we have so many issues. Understanding, guys? Understanding? Yes. The midgut rotation occurs in a counterclockwise direction around which structure? Again, this is a very simple question. Superior mesenteric artery. Same question, but this, can you guess why I have put the question twice? Because it is that important. You should know the axis around which the rotation is taking place. Next, the small intestine formed from the cranial limb returns first. Okay, the small intestine, as you can see, which is formed from the cranial limb, has returned first. Then it passes posterior to the superior mesenteric artery and occupies the central part of the abdomen. Then the large intestine returns. It undergoes further 180 degrees of counterclockwise rotation. It basically uncoils itself, and that comes to occupy the right side of the abdomen. First, what happens? What is the first structure to return? It is the small intestine. Small intestine is the first structure to return. Okay. Then after that, I have the large intestine, which undergoes a 180-degree counterclockwise rotation, and it further enters into the abdominal cavity. Understood how the midgut loop was formed, understand how the rotation of the midgut took place, and then let's say this is cranial and this is caudal. Then cranial came onto the right side, caudal came onto the left side, and then they started returning back to the abdominal cavity, and the large intestines that were formed, they again underwent a 180-degree counterclockwise rotation, and they returned back to its position. Okay, yes. Next, let us look at the cecum and the appendix. Cecum and the appendix. The primordium and for the cecum and appendix was, I've already told you, it is the cecal diverticulum. That is a primordium of cecum and appendix, which is the cecal diverticulum that appears around 6th week as a swelling on the anti-mesenteric border of the caudal limb of the midgut. Okay, next, this apex of the cecal diverticulum does not grow as rapidly as the rest of it. So that is why you don't have the migration of cecum and appendix as such. Appendix is initially a very small diverticulum of the cecum. Okay, you can see here, this is the cranial limb of the midgut loop, and this is the caudal limb, and this is the cecal diverticulum. Okay, and this is the mesentery through which all of this is hanging, and this is the yolk stalk. Next, from the cecal diverticulum, you have the formation of the cecum. And what is appendix, guys? Appendix is nothing but a small diverticulum of the cecum itself. Parent organ of the appendix is cecum itself. Okay, parent organ of the appendix is cecum itself. And the hostrations over here you have is tinea coli. All right. Yes. Next, appendix increases rapidly in length so that at birth, it is a relatively long tube arising from the distal end of the cecum. Look at this, guys. Appendix is, look at this, how it is increasing in its size. Is it not? It was very small. Now it is increasing in its size. After birth, the wall of the cecum grows unequally, with the result, the appendix comes to enter the medial side. All right. But the fact is, appendix is, it is variant in position, that it is sometimes it's retrocecal, retrocolic, or sometimes it can be present in the pelvic cavity also. It can be present in the pelvic cavity also because it is a long tube. It sometimes lies medial to cecum or behind cecum. You don't know where. That is why appendix surgery is generally done by under the supervision. Junior surgeons, they always do appendicectomy under the supervision. Okay. Yeah. Then, so the appendix is considerably variant in position, where it can be retrocecal behind cecum, retrocolic behind colon, or sometimes in the pelvic cavity. Okay. Next, let's look at the derivatives of the hindgut. What are the derivatives? I've already told you. The left one half of the transverse colon, descending and sigmoid colon, rectum and superior part of anal canal, and epithelium of the urinary bladder, and most of the urethra. But hindgut is also, it is coming from yolk sac only. It's not coming from somewhere else. It's coming from the yolk sac only. All three gut, midgut, foregut, hindgut, they're all coming from yolk sac only. Okay. Different structures from the hindgut are all of these. All right. Next, all the derivatives are supplied by the inferior mesenteric artery. All the structures are supplied by inferior mesenteric artery. Okay. Now, the junction between the segment of transverse colon that is derived from the midgut and that originated from the hindgut is indicated by change in blood supply. Suppose, guys, if this is the transverse colon, right? So, till here, right? 2/3, and this is the left 1/3. This part until here, the cecum, the appendix, and all of the ileal loops and everything, it is all, this is by the development is from midgut. Next, the region of this 1/3, and then you have the rectum and the anal canal, and all of these are derived from the hindgut. Okay, the midgut is supplied by superior mesenteric artery. The hindgut is supplied by inferior mesenteric artery, whereas the foregut was supplied by celiac trunk. All three arteries are branches of abdominal aorta. They are the direct branches of the abdominal aorta. Okay, the junction between the segment of transverse colon that is derived by the midgut and that originated from the hindgut is actually marked. How do you know which is from which is actually marked by the change in the blood supply? That is, this area is supplied by the superior mesenteric, this area is supplied by inferior mesenteric artery. Superior mesenteric artery is the midgut, inferior is the hindgut artery. Very important, guys. The foregut artery is celiac trunk, superior and inferior is midgut and hindgut respectively. Okay, the descending colon becomes retroperitoneal as its mesentery fuses with the peritoneum on the left posterior abdominal wall, and finally it disappears. Okay, the mesentery of the sigmoid colon is retained, but it is shorter than as it was in the embryo. Let's look at the cloaca. What is this cloaca? Okay, now the terminal part of the hindgut is an endoderm-lined chamber that is in contact with the surface ectoderm at the cloacal membrane. Guys, I've explained this so many times, right? Why here I have a structure which is lined by an endoderm and is in contact with the surface ectoderm, and there is no structure which is derived from the mesoderm. I've explained this so many times. Why? Because when the mesoderm was forming, right? When the mesoderm was forming, when the primitive streak was formed, it started replacing all the layers that were there in the, then it started replacing all the layers, right? What are the layers that we had? We had an epiblast and we had hypoblast. Correct? Epiblast and hypoblast, what did it do? It invaginated and replaced all the hypoblast cells to form endoderm. After that, it formed mesoderm. After that, it replaced the cells of epiblast also and it formed ectoderm. The mesoderm that is formed over here, it was spreading everywhere. It was spreading everywhere. It even spoke with the extra embryonic coelom and mesoderm and everything. But there were only two regions, two places where the mesoderm was absent, where it left out. What were those? Buccopharyngeal membrane and cloacal membrane. So the cloaca which is present over here, right, which is at the cloacal membrane, has just the endodermal cavity and it is lined with surface ectoderm. But it does not have mesoderm. Why? Because of this process. Buccopharyngeal membrane forms oral cavity, whereas cloaca forms anal region. Okay. Now this membrane is composed of endoderm of cloaca and ectoderm of proctodium or anal pit. See how you can correlate things. This is the beauty of embryology. Whatever we learned in general embryology is just the advanced version. Please do these correlations, guys. It becomes very easy. Then the cloaca, the expanded terminal part of the hindgut, receives the allantois. All right. Yes. Next, partitioning of cloaca. Now the cloaca is divided into dorsal and ventral parts by a wedge of mesenchyme called urorectal septum. Okay. Now this develops in the angle between the allantois and the hindgut. As the septum grows towards the cloacal membrane, it develops fork-like extensions that produce infoldings in the lateral walls of the cloaca. Further, these folds, they grow towards each other and fuse to form a partition that divides cloaca into two parts. Okay, the rectum and the cranial part of the anal canal. So basically, in the tube, there is a partition that is formed. Correct? These folds, they grow towards each other and finally, that divides cloaca into two parts. One is the rectum and another is the cranial part of the anal canal. Cranial part of the anal canal. Not very important for you guys. Okay. Next, by 7th week, the urorectal septum has fused with the cloacal membrane, dividing it into dorsal membrane and a larger ventral urogenital membrane. Okay. This point is important, guys, because the area of fusion of the urorectal septum and the cloacal membrane is represented in the adult by the perineal body, which is very, very important. Okay. Perineal body is very important when it comes to females, right? During labor, this perineal body is the one which supports. Correct? Yes. Next, the perineal body is a fibromuscular node and a landmark of perineum where several muscles converge and attach. Okay. Now, this urorectal septum also divides the cloacal sphincter into anterior and posterior parts. Posterior part becomes the external anal sphincter. Anterior part develops into superficial, transverse perineal, and bulbospongiosus and ischio-cavernous muscles. Okay, not very important for you guys. Next, this developmental fact explains why one nerve, that is the pudendal nerve, supplies all these muscles. Because what is the parent? What is the parent here? What is the parent? It is the urorectal membrane, which is fused with the cloacal membrane. All right. So because all of these muscles are supplied by pudendal nerve. Right. Next, the anal membrane usually ruptures at the end of 8th week and brings the distal part of the digestive tract into communication with the amniotic cavity. Then anal canal. Again, guys, it's not very important for you. I'm just going through this because it just gives a very nice sense of completion of the topics. But what is important is, number one, the midgut rotation that I taught you, and when the intestines actually come back and how the large intestine undergoes a 180-degree counterclockwise rotation. That concept is important. Number two, artery supplying, and number three, derivatives of each. So these are the three components which are important for us, but rest everything else is for the sake of completion. Okay, can just go through these slides once, right? No harm in just knowing this, right? Next, the junction between epithelia of the two parts is indicated by an irregular pectinate line. Okay, the line is located at the inferior limit of the anal valves, which indicates the former site of anal membrane. The anal membrane, it usually ruptures at the end of 8th week. Correct? Correct. Now this pectinate line, the one that is formed as irregular pectinate line, indicates the former site of the anal membrane. Okay. This is the pectinate line that we have. From here to here, it is still the hindgut. Below the pectinate line, it is from the proctodeum. And then this is anus. Okay. Next. About 2 centimeter superior to the anus is an anocutaneous line or white line. White line demarcates the anal epithelial changes from columnar to stratified squamous. At the anus, the epithelium is keratinized and continues with the skin around the anus. Because of its hindgut origin, the superior 2/3 of the anal canal are mainly supplied by superior rectal artery. Okay. The inferior 1/3 is mainly supplied by inferior rectal arteries. So basically below this, below this pectinate line, we have something called as white line. So white line is the demarcation of the epithelium, which changes from columnar to stratified squamous epithelium. Okay. Yes. And also towards the the 1/3 of the anal canal is actually keratinized epithelium as well. Next, let us look at some important congenital malformations. All right. Now, what did I teach you? First, what happens? There is a communication between extraembryonic and the intraembryonic coelom, and all whatever the developmental contents that I had, like the intestines and everything, they were physiologically, they herniated out and they returned back. One second. And they returned back into the midgut. Okay. Now, suppose if these contents, right, we had intestinal loops which were there, the developing intestinal loops did not come back to midgut, what happens is congenital omphalocele. Congenital omphalocele. The herniation of intestines into the cord occurs in about 1 in 5,000 births, and herniation of liver and intestines in 1 in 10,000. Size of hernia depends upon the contents. Okay. Now, in case of omphalocele, whatever the contents that are herniated is always covered by a bag of membrane. So if you look at the diagram, you have a baby who, all of these, what is the site of herniation, guys? It is the umbilicus. Umbilicus is the site of herniation, isn't it? Physiological herniation is the umbilicus. That is the site of herniation. So if it remains, then it becomes pathological. Is it not? If it remains, then it becomes pathological. Here, when the baby is born with congenital omphalocele, you will see a baby and the, if this is the umbilicus, and all of the contents come out like this, and which is covered by a sac, which is called as omphalocele. If the sac is not there, then it is called as gastroschisis. Same, if the sac is not there, then it is called as gastroschisis, which is generally towards the right of the umbilicus. Okay. Now, omphalocele results from the failure of intestine to return to the abdominal cavity, and an immediate surgical repair is required because you cannot let these structures exposed. It will result in severe infection and the baby may die. Okay. The covering of the hernial sac is the epithelium of the umbilical cord, which is a derivative of the amnion. So it is always covered by a sac, which is the in case of omphalocele. If the omphalocele sac is not present, then we call it gastroschisis, which is generally towards the right side of the umbilicus. Okay. Then there is something called ectopia vesicae, which we will study in urogenital system, that I'll tell you tomorrow. But these are the three important images that you should be familiar with. That is omphalocele, gastroschisis, and ectopic vesicae. Right? These are the important. The bladder is exposed in case of ectopia vesicae, that you have to be familiar with. Then we have umbilical hernia. But what happens is, in umbilical hernia, difference between omphalocele and umbilical hernia is that in omphalocele, the contents don't even come back to the abdominal cavity, whereas in umbilical hernia, the intestine return back to the abdominal cavity, but then they herniate through an imperfectly closed umbilicus, as then the umbilical hernia forms. Okay, this is different from omphalocele. Why? Because in omphalocele, the intestines did not return at all. They did not. After the physiological herniation took place, it did not return at all. But in umbilical hernia, the contents returned, but then they herniated through an imperfectly closed umbilicus. All right. How does it present? How does the baby look like? It's nothing but a protruding mass that is covered by subcutaneous tissue and skin. This is the buzzword here. If the content that is protruded outside is covered by a sac, covered by the sac or a membrane, then it is omphalocele. If it is covered by subcutaneous tissue and skin, then it is umbilical hernia. And even umbilical hernias will be much smaller as compared to omphalocele. Okay. Yes. It usually ranges from 1 to 5 centimeter. It is a defect through which the hernia occurs with linea alba. Okay. Linea alba what is linea alba, guys? It is the place where all of the abdominal come and attach, and they form a cartilaginous, not cartilaginous, and the fibromuscular band that we have, right? And it protrudes during crying, straining, and coughing. Okay. Now it generally happens after first month, and it can be easily reduced through the fibrous ring at the umbilicus. Okay. Surgery is usually not performed until it persists to the age of 5 to 7 years. So that is why when you actually examine a newborn, right, you particularly will have to comment about umbilical hernia, because it is quite common and many babies may have this, but then it gets reduced on itself. You don't need to intervene unless there is a torsion or infection and so on. Okay. You will have to comment upon whether the content or the state of the umbilicus, whether it has any any content protruding out or not. Okay. Now we have Meckel's diverticulum. So what is Meckel diverticulum, guys? Meckel's diverticulum is an output pouching in one of the most common anomalies of the digestive tract. Okay. Sometimes the Meckel diverticulum may become inflamed, and it causes symptoms that mimic the appendicitis. It mimics the appendicitis. Okay. The thing is, wall of the Meckel's diverticulum contains all 3 layers of the ileum and may contain some small patches of the gastric and the pancreatic tissues as well. Gastric mucosa, if it is present, secretes acid, producing ulceration and bleeding. Is it not? And it is the remnant of the proximal part of the yolk stalk. Yolk stalk and everything they should not be present in a normal baby, right? But if it is present, then it is called as Meckel's diverticulum, which appears as a finger-like pouch about 3 to 6 centimeter long, and it is a true diverticulum. It is not a false diverticulum. It is a true diverticulum. It arises from the anti-mesenteric border of the ileum 40 to 50 centimeter from the ileocecal junction. Okay. Meckel's diverticulum is actually a very important surgery topic. I've just included this to, to show you what happens if the development does not happen properly and normally. All right. Next, as a part of the colon, next we are going to congenital megacolon. Congenital megacolon. Name says congenital, developmental anomaly. Mega meaning big. Big colon. How does it happen? Because here the colon is dilated because of the absence of the autonomic ganglion cells in the myenteric plexus distal to the dilated segment of the colon. See what is happening, guys. In yesterday's class, we were talking about achalasia cardia, where we did not have these ganglionic cells in the lower end of the esophageal sphincter. Because of that, the lower end of the sphincter was not able to relax. It was not able to relax because of this. And that is why we had recurrent episodes of GERD and everything, right? And the treatment was we could inject, botulinum toxin and so on. There are many surgeries also which are done for this. But here in the congenital megacolon, you don't have the ganglionic cells in the myenteric plexus in one segment of the colon. Suppose, guys, if this is the colon, transverse colon, let's say, this is the abnormal segment and this is the normal segment. Normally, what should happen? The food enters here, and there, by the process of peristalsis, food from this normal segment should go to this segment and should go to the next segment and so on. In congenital megacolon, peristalsis meaning it should contract so that the food gets pushed to the next segment. Next segment should contract so it goes to the further. And this process continues. In congenital megacolon, what happens is the ganglion cells over here are absent, because of which this particular segment is not able to push the food to the next segment. Correct? Because of this particular segment is not able to push the food or whatever the content into the next segment. As a result, the segment that is distal to that, the segment that is, the segment that is present next to this normal segment, it dilates. Why does it dilate? Because it is pushing and pushing and pushing the food, but this abnormal segment is not able to carry the wave of peristalsis further, because of which all of the contents get accumulated here, and also it starts to distend. What is distended over here is not the abnormal segment, rather the normal segment that is present next to the abnormal segment. Okay? The aganglionic segment that is present, which is the abnormal segment, is not the one that is dilated. The one that is normal, which is next to the aganglionic segment, is the segment that is dilated in case of congenital megacolon, because it is trying to push with all its energy and efforts to continue the peristaltic wave. But abnormal segment does not have ganglion. It cannot contract. So the one that is present next to it gets dilated. That is called as congenital megacolon, one of the very common causes of neonatal obstruction. Okay, neonatal obstructions here, males are more commonly affected than the females. It results due to failure of the neural crest cells to migrate into the wall of the colon during the 5th and 6th weeks. All of these are very important surgery questions. Then we also something called as imperforate anus. Again, all of these are very common in males. Okay, most anorectal anomalies result from abnormal development of urorectal septum. All right. Yes, not very important for you guys. There are imperforate anus and all. Just you have to know that it's an abnormal condition because of the abnormal development of urorectal septum. That's all you must know, because these are all surgery topics, not in anatomy. They'll not be asked much. Okay, let's take some question. Failure of midgut to rotate properly can lead to which of the following conditions? Intestinal atresia? Question mark. We haven't talked about it. Omphalocele? Yes, yes, it can occur. Just now we told you. Volvulus, yes, it can occur as well. Intestinal atresia can also occur. We have duodenal atresia, which is seen as a double bubble sign, right? On X-ray, if you see, seen in double bubble sign, which is most commonly seen in case of Down's syndrome. Jejunal atresia is actually seen as a triple bubble sign in X-ray. So all of these things you study in your surgery, but it can happen. Which of the following is a characteristic feature of malrotation of the midgut? Normal positioning of the duodenojejunal junction. Is it? Of course not. We are asking which of the following is a feature of malrotation, not the normal rotation. Due to malrotation, what happens? Absence of omphallomesenteric duct? No. Absence of mesentery? Of course not. Mesentery will be present. What has it got anything to do with malrotation of midgut? Mesentery is present throughout. Abnormal positioning of the cecum in the right upper quadrant is the answer, because where is cecum present? If you divide the abdomen into 9 quadrants, cecum is present here. It is present in the right lower quadrant. Is it not? If it goes into the right upper quadrant, then it is abnormal. What is there in right upper quadrant? Liver. So what is important here to understand in these two classes is, number one, the derivatives of the gut. Number two, the arteries supplying them. Number three, malrotation or the rotation of the gut and how it takes place. Number four is different conditions that happen because of the intestines failure of the intestines to come back to abdominal cavity. So these are the very important things in this class. I know this was again a little, I would say, more than required, but having knowledge on things that are not important will never hamper you scoring from good marks. It will always improve your chances of scoring very good marks. All right. So we will now wrap up the class. And in today's class, we studied about the development of midgut and the hindgut. And in yesterday's class, we studied about the development of foregut. In the tomorrow's class, we'll be done with urogenital system. Okay. Very interesting classes, guys, and I hope you have found these classes useful and you're enjoying studying embryology. And embryology is no more a dreaded and subject that you don't understand. I really hope you have understood what I have taught you, and I wish you guys all the very best. I'll see you in next class. All right. Thank you.